In a society where many institutions feel weakened, the NHS and the solidarity, the social solidarity that the NHS represents, is still a very powerful source of cohesion for us. It belongs to us all. We all have a relative or a neighbour who works in the NHS. We've, I guess, probably pretty much all of us experienced it at first hand as patients. We're all stakeholders through the taxes we pay and the entitlements we enjoy. So today, what I want to do is to talk about how our values in the Conservative Party are shaping our view of how healthcare should be delivered, and to contrast that with what I fear has happened over the last decade. Let me start with our values. If I was asked to choose one word to sum up the Conservative Party's vision for a changed Britain, it would be the word responsibility. Responsibility goes to the core of all the changes we'll seek to make. Why? Because so many of the current problems can be traced to a lack of responsibility in society. Fathers who walk out on their families and feel no sense of duty towards them. Teenagers whose idea of fun is to get blind drunk and vandalise town centres. Bankers who thought only of profit and not of risk. And of course, members of Parliament who let you down as your elected representatives. You know, it's the responsibility of those you elect to behave properly, not just legally, not just within the rules, but to the highest standards. Those who are elected for public office should be, we believe, beyond reproach, and that's why David Cameron and I, 2 weeks ago, we paid back expenses claims, not because they were outside the rules, but because we understood that what the public were looking for were the highest standards, and they did not feel that those highest standards had been maintained. And it wasn't good enough for us to say they were within the rules, because they were rules that were established by members of Parliament and not on behalf of the public themselves. And if we are going to and aspire to enjoy trust in the future, and even more so, frankly, to exercise responsibility for public money in the future, we have to show that we get it about that responsibility as it has applied not only now and for the future, but in the past. Of course, we have said for many years now that the modern Conservative Party stands for social responsibility, not state control. And as David said earlier this week, to bring about a more responsible society, we need actually to give people responsibility. We need a radical redistribution of power from the state to the citizens. Through decentralisation, through transparency, through accountability, we have to take power away from political elites and establishments and hand them to the man and woman in the street. And in public services, that demands a radical shift in the distribution of power. Nurses, doctors, teachers, professional judgment has been steadily eroded by a top-down, tick-box target culture. That's why a Conservative government will scrap that kind of top-down target, process target-driven approach, and instead focus on what really matters, the results we achieve. We would trust doctors and nurses to do what's best for their patients and focus on the outcomes they achieve rather than the hoops they are made to jump through by Whitehall targets. When you think about it, there's no greater expression of collective responsibility of our duty to our fellow citizens than the National Health Service itself. Collectively, we are committed to pay for, to look after and care for the frail and the sick in our society, regardless of their circumstances. That's something I think we're all proud of, and as a society we should not only sustain but continue to be proud of that. And we are determined future generations will still be supported by the National Health Service, that those core values will be maintained. That's why my colleagues in the House of Lords amended the current health bill so that those values will be incorporated into statute and they cannot be changed without further reference back to Parliament. But we can't stand still. It's not just about core values being sustained for the future. It's that the sense of security and equity that the NHS engenders in us cannot be enough. We also have to, alongside equity, build excellence. So we're determined the NHS will go from strength to strength under a Conservative government in the future, whatever the vicissitudes of public finance may be. We are determined that we will deliver healthcare that is amongst the best in the world. A recession is bad enough. We are determined that we will not subject people to the additional insecurity and anxiety of feeling that their healthcare needs may not be met if they have to be met. The opportunity is great. If we were to achieve results as good as any in Europe, up to 100,000 more lives could be saved, premature mortality could be avoided each year if we met the best standards anywhere in Europe. Now, to me, that's a bold vision, but I don't see any reason why we cannot achieve it. We have the medical research, we have the medical technology developed in this country, we have amongst the best clinicians anywhere in the world, we have amongst the best nurses. We have the capacity to do this thing, we're just not yet organised to do it. Of course, we need to face up to what's behind so much of the demand on the NHS, and if we are going to do this, we need to start to take responsibility for improving such things as our diet, our activity levels, or our use of alcohol. We have to moderate through responsibility the demands on the NHS, but within the NHS also we need to start trusting doctors and nurses more to do what's best for patients instead of burdening them with the tick box target culture and the hoops they have to jump through. I mean, nurses freed from mountains of paperwork must get back to the bedside and refuse to accept excuses for poor standards of care. GPs, properly rewarded, must step up to the plate and take ownership of the patient's whole pathway of care. For me, I believe that there can be no greater responsibility than to be entrusted with improving our nation's health service. Let me make a contrast here for a moment. People could be forgiven for saying, well, that surely is equally true for Alan as current Secretary of State. But instead of driving through key reforms in the NHS, Alan seems to be eyeing up another job. And the needs of the NHS appear not to have been pursued as a result. I mean, three and a half years ago, I made it very clear, back in 2006, that we, the Conservative Party, were offering our support for reforms that would give patients more power through competition and choice. I said that in precisely these terms. We desperately wanted the NHS to succeed in this Parliament so that it can do even better in the next. So it's been really disappointing to me that over these last few years, particularly in these last 2 years, the reforms that begun under Alan Milburn and Tony Blair have stalled under Gordon Brown and Alan Johnson. See, back in 2006, Tony Blair said, and I quote, "Changes in health and education are difficult, challenging, but essential to deliver the 21st century services the public expects." And he said, Tony Blair said in a speech then in 2006, that he believed there were 4 drivers of reform in the National Health Service: patient choice, independent sector involvement, practice-based commissioning, and foundation trust, those 4. Now, each of those are necessary, even if not necessarily in precisely the form in which he was proposing them. I don't think actually, as I will go on to explain, they are sufficient. They are necessary but not sufficient drivers of reform. But even so, let's just stick with those 4 Blairite drivers of reform. Let's take the first, patient choice. Alan, of course, published a primary care strategy in July of last year. Sounded good. We'd all be able to choose our GP until you begin to look at the detail. Not only had it been said before in 2006, but it hadn't been implemented. And it still isn't being implemented. GPs still have fixed practice boundaries. They're not allowed to accept patients beyond those boundaries. That's a solid wall of defence against real choice. Unless and until we can break down those barriers to choice in primary care, we will not make patient choice a reality. And the government said there would be choice of hospital, where you go to have your operation. By April 2008, everyone was going to be offered a choice of hospital. But the experience of choice on the part of patients reached 46% and stuck. In the last 2 years, it has gone up by only 3%. The majority of patients still feel themselves to be in exactly the same situation they used to be in. So what about the second driver of reform, opening up the NHS to new providers? What the government had done up to that point was to negotiate contracts with independent sector treatment centres. I have to say, from my point of view, badly designed because they didn't get value for money and because they saw the involvement of the independent sector as an add-on rather than an integral part of the reform process. And I'm afraid that's precisely where Alan currently sees it. Just a few weeks ago, he said that involving the independent sector was about capacity, not competition. And in the context, the implication of what he was saying was, and if we have enough capacity in the hospital sector, we don't need the independent sector at all. So from the independent sector's point of view, it was pretty much a cold message about their long-term capacity to invest for new services in the NHS. And I think he's wrong about that. I think opening up to new providers is as much about competition as it is about capacity. What about the third one, giving GPs commissioning power? Well, Tony Blair was just talking about notional budgets, but that too has stalled. The Audit Commission made clear in their report on practice-based commissioning that it's not being driven forward. The reality is that offering patients a choice of hospital, for example, will only be effective if it is backed up by the power in the hands of GPs for commissioning. They're the ones who can really help us as patients to manage our care more effectively because we have it allied to control over budgets and to a clinician's relationship with other clinicians through the system. They're the interface between us and the health service. They can hold hospitals and healthcare services to account through refusing to send patients to services that don't match up to the best standards and negotiating our way through. It's one of the real frustrations to me as a Member of Parliament. How often I have had people who are talking to me about trying to manage their way through the health service and the services provided to them. And I say to them, well, what does your GP think about this? And they say, oh, Dr. So-and-so has been marvellous, but of course has absolutely no control over this whatsoever. Well, who is better placed than the person that patients most trust, which is very often, as they see it, their family doctor, who has the clinical knowledge and capacity to be able to negotiate and to manage this process, and who ought then to have the power and the responsibility through budget holding and commissioning to be able to do it. But since December last year, the number of GP practices even holding notional budgets has actually gone down by 5%. And those notional budgets have their severe limitations anyway. There's no ability to, at their own instigation, to make savings and to reinvest them on behalf of patients. There's no ability to negotiate and hold contracts. Real budgets will give GPs real power to respond to patient choice. But the government, and indeed the bureaucracy inside the NHS, simply will not let go. What about the fourth driver, foundation trusts? Supposed to be completed by December 2008, but stalled again. So we still have an NHS bureaucracy, particularly strategic health authorities across the country, who control both commissioners and providers, who have a foot in both camps. So 20 years, it is the 20th anniversary this year of the so-called purchaser-provider split in the National Health Service, and it hasn't happened. The tragedy of the Blairite healthcare agenda is that the only driver of reform he really delivered on was the one that was always going to have the most problems from the health service's point of view. That was introducing more and more process-driven top-down targets centrally set in Whitehall. Now, there are problems linked to targets. Let me quote a former advisor to our former Prime Minister, who said, and I quote, "The downsides of targets are several. One is that you get perverse outcomes. People focus on one target at the expense of others. A second problem is that people cheat, but perhaps the biggest problem of targets is that they deny autonomy to frontline managers." I think Matthew said that. Week in and week out, I talk to NHS staff who agree with that. And I'm not saying that the government's intentions were bad. Tony Blair wanted the NHS to raise its game, of course he did, holding hospitals to account for the most obviously measurable aspects of performance seemed like the way to drive reform. But he didn't bargain for all those perverse side effects. Where boxes have to be ticked, there is little space for professional judgment. Where targets are the priority, non-targeted parts of a patient's treatment get left behind. Where part of the process is the target, by definition, outcomes are not the target. And that gap has been a deeply worrying gap, because it has also, at the same time, those focuses on processes have led to a proliferation of bureaucracy. And nowhere was this shown more clearly than in the recent Healthcare Commission report on the tragic events at Stafford General Hospital. The Healthcare Commission quoted what staff at the hospital thought. They said, and I quote, "The approach of the Trust meant that the care of patients had become secondary to achieving targets and minimising breaches." It simply cannot be right to have regarded that patients were seen and discharged out of an emergency department within 4 hours as a sufficient measure of the quality of the emergency care being provided by a hospital. In fact, we know it wasn't sufficient. And just to say that, well, Stafford is an exception to a rule is to misunderstand what the evidence shows us across the country. That Stafford was at the end of a spectrum may be true, but that it is a case apart is not true. That the impact of targets leads to those kind of compromises being made far too often in far too many places. And the government still says, I've heard Alan say, targets are not responsible for what happened in that hospital. By implication, local managers are responsible for what happened in that hospital. And that's not good enough either, because precisely the thing that the autonomy of frontline managers is undermined by a top-down target culture is precisely what happened at Stafford, that the managers were focused on the things that determined whether or not they were held by their superiors to have succeeded or not. And that was not the quality of care of patients. It was the achievement of foundation status and the meeting of targets that were required in order to make that happen. So, Alan has done some things which, over these last 2 years, have no doubt, from the NHS point of view, benefited. There have been things like work on prescription charges. We've pushed him into another, but now more substantive, commitment on eliminating mixed-sex wards. But actually, most of what Alan's been setting out to do, and frankly, in private, they make no bones about it in the Labour Party, his strategy was simply to take health out of the headlines. And in 2 years, the last 2 years, when the resources available to the National Health Service have been rising faster than at any time in its history, simply achieving surpluses in the National Health Service was the straightforward bit. Achieving more with those resources, that's the hard bit. And that's the bit where reform would have made that difference and didn't, because it was meant to be investment with reform, but it turned out to be investment without reform. So, for example, when Maidstone and Tunbridge Wells came up, Alan really didn't respond to that. It was somehow something that just happened out there, make it go away. And of course, it may have gone away at Maidstone and Tunbridge Wells, but exactly the same kind of issues came up at Stafford. And to fail to respond adequately once is unfortunate. To do it twice is careless. Alan said of himself, he said, "I just drift along," but frankly, that's just not good enough. What we need when you're responsible for a public service upon which so many people depend so much, we need positive long-term vision, making the NHS the best it can possibly be. So we need a health secretary who understands the importance of consistent reform, one who tries to tackle the challenges head-on. Take health inequalities, for example, which Alan says was his principal objective. We haven't seen change and we haven't seen action, and we have seen health inequalities widen to some of their greatest levels at any time since Victorian times. Life expectancy gaps widening and infant mortality gaps widening. When the Foresight report was published on obesity, Alan said this is a challenge on the scale of climate change. But then what did we get as a result? We got a working group about dancing, which may have been strictly true, but wasn't sufficient. The Foresight report, which is a very important report, made it clear that we are dealing with a multifactorial problem. What we require is a comprehensive strategy in order to make it happen. What we have seen too often, for too long, is simply an initiative that gets you through a publication and then everybody just moves on to a different subject, and that isn't good enough. Or dentistry, reviews. Government knows there's a problem. They know people aren't finding access. They know we've got 2/3 more children having tooth extractions. We know that it requires change. But what we haven't had is any proposals to make that happen. And we had a strategy published, for example, to give you one more example, on dementia. We know the scale of the personal, social, family problems, and indeed healthcare problems that will result from dementia. But we were told, there's new money. And then we asked, well, where is the new money? And the answer was, well, it's already in the allocations that have gone out to primary care trusts. We asked about where's the focus on research, and we're told, well, the research isn't in the strategy, we hope it'll come later, and it hasn't yet come. There is no research strategy yet. And we asked about antipsychotic drugs. We've got 120,000 people who are suffering the indignity of having antipsychotic drugs given to them in care homes in circumstances where, frankly, there are alternative and better courses of treatment available to them. And nothing in the strategy about antipsychotic drugs. So, from my point of view, both in the particular and in the general, the NHS needs better. For me, leadership matters. I want to give leadership to the National Health Service. I don't want the NHS to be seen as a stepping stone to the leadership for anybody. Now, what we need to do, let me go back to those Blairite reforms. We need to deliver on some of those reforms by making them work not in the way that they were originally designed, but in the way that is best designed for the National Health Service. We need the delivery that goes with that. Alan hasn't delivered, He kind of boasted to us in the House of Commons a couple of weeks ago. He said, well, I used to be a postman, so I always deliver. But he hasn't delivered. And we do need delivery in the future. For us as a party, for the Conservative Party, restoring trust in politics isn't just about constitutional change, and it isn't just about whether we have a robust system of expenses and allowances in Parliament. The fundamental issue about trust is that for maybe 20 years, the people of this country have not felt that governments they elect are clear about what they're trying to achieve and achieve it. And that's how we will rebuild trust in the broadest sense in the political process. Now, the years ahead will not be easy. David Nicholson has already told the NHS that efficiency savings of between 15 and 20 billion are going to be required. And let's face it, that must be real efficiency savings. Just simply taking 10% out of a budget by doing 10% less is not an efficiency saving. Doing more for less is not just about cutting budgets. Doing more for less is about delivering more with the resources that you have available. Because the NHS is not going to have its resources cut. I mean, it's rather depressing for me how many people are saying to me, well, of course, Mr. Lansley, tell us what it's going to be like when you have to cut the NHS budget. I'm not going to cut the NHS budget. We are not going to do so. The issue is not about cuts in the NHS. The issue is about already delivering more for the resources that are there, so that the additional resources that we know will be needed to meet the challenges of ageing population, of people living longer with chronic conditions, of rising technology and expectations, that we can use the additional resources to improve the NHS, to meet that gap between where we are in terms of health outcomes as a country and where we need to be. And that will require consistent reform, not a stop-start approach, but something where, because as a government we are able to let go and give the NHS greater autonomy in how it delivers its services, we have to construct a structure that is consistent and long-term. By definition, if we let go more, we can't be trying to interfere day by day in the way in which the NHS does its job. So we need persistent, consistent reform. Now, it will include patient choice, real patient choice. It will include a plurality of providers, both NHS providers that enjoy greater independence and new providers who come into the system. It does require devolved decision-making beyond what was intended under practice-based commissioning, as I described earlier. But it also requires, which has not been in the reform process so far, a clear distinction between commissioners and providers. It requires, frankly, a revolution in terms of information, not just IT, although we do need information technology to be properly used inside our health service, properly and cost-effectively. But it's also about high-quality information on service standards, on access, on quality, and on results in a form which has not been available up to now and needs to be available to empower choice and commissioners. And we need accountability to be different. We need accountability not for narrow processes, but for outcomes. And what we also need a new priority for public health, because public health requires reform too. We need a stronger infrastructure rather than one that has been weakened over years. We need separate funding instead of constant raiding of public health budgets and preventative care in order to meet immediate treatment demands. And we need a change in terms of responsibility at family, community and individual level. And we need that to be across public and private sectors. And it must require us to focus on lifestyle and behaviour. Self-respect and self-responsibility amongst adults, self-esteem amongst young people. And some of you will have heard me say before, if there's the one thing that I know is important, where it is most difficult for government to effect change, but where the change, if we can, through leadership, make it happen, is going to be the most substantial impact long-term on the prospects for this country, is it if we have generations of young people who enjoy greater self-confidence and greater self-esteem and who feel themselves empowered to make positive decisions about their lifestyle and behaviour, instead of being, as they appear now to be, so dreadfully susceptible to peer pressure and external pressures of all kinds. That is a transformation. We know it for our own children. I guess you know it for your own children. And that is something we need to understand as a society and to make happen. Within the National Health Service, we need reform, but not reorganisation. No more upheavals. Reform and reorganisation actually conflict with one another. It is partly because we've had 9 reorganisations in 10 years that some of the drivers of reform have never taken hold and been implemented consistently. We need to put patients at the heart of the service. We need to empower health professionals. We need an information revolution. We need information to drive choice. We need that choice to be real and for the service and the professionals in the service to be accountable to patients who exercise greater control over the management of their care. We need a focus on results and the NHS to be accountable for that. By doing so, we as a government want to be clear with the health service about what we are trying to achieve, but we do not want to try to interfere and tell people how to do it. And there is a big distinction between those two things. So then we have a service, we hope, empowered to provide quality care, focused on improvement, continuous improvement, measured by outcomes. And therefore, because it's focused on outcomes, has the freedom also to innovate. Because through innovation comes that opportunity to, as it were, to have the first mover advantage in terms of delivering better outcomes that, of course, puts you in a strong position in a choice and patient-centred system. Now, you don't do that through a quango. You have to do that through exposing a service to contestability. So as Conservatives, we will keep what works and we will reform what doesn't. We will drive reform through the principles of choice, of devolution, of competition and of professional responsibility. In place of constant upheaval will come consistent reform. All over the world, countries are looking for health systems which provide a magical combination of equity, of efficiency, and of excellence. In this country, unlike many other countries, especially perhaps looking at America, we have an equity-based service. I think we used to be efficient. We always used to say the NHS gives the greatest value for money anywhere in the world, but we have had a decade of rising unit costs and falling productivity. We have to recover that efficiency through the delivery of choice and competition. In the years ahead, we know we have to maintain the equity by focusing on a taxpayer-based service where people access their service based on their need, not on their ability to pay. We need fair allocations across the country and evidence-based standards so that the equity is not only at an individual level, it's also between different places across the country. But by giving patients greater control through choice and competition, we will drive efficiency and rising productivity. Through professional empowerment and a focus on outcomes and the delivery of quality information, we will drive excellence. That's my vision. That's the kind of leadership that I think the NHS wants. It's the kind of leadership I would aspire to give about delivering equity, efficiency, and perhaps most of all, excellence. Thank you very much.